Assalamu alaikum. I am excited to take you through and discussion on bleeding disorder. In bleeding disorder, what are the type of bleeding disorder? It may be clotting defect, it may be platelet defect, or it may be thrombocytopenia. In bleeding disorder, like in clotting defect, cause is or symptom hemarthrosis, and there may be deep tissue hematoma. Example, hemophilia A, hemophilia B. There is increase A, P, T, T activated partial thromboblast in time, and platelet aggregation defect. Platelet aggregation defect is von Willebrand disease, Bernard-Soulier syndrome, and there may be thrombocytopenia. There may be ITP, there may be leukemia, where there is low platelet count, and in platelet aggregation defect and in thrombocytopenia there may be easy or prolonged mucosal bleeding, ecchymosis, and there may be petechiae. Okay, let's talk about clotting disorder in a broad picture. Okay, clotting coagulation disorder. In coagulation, always remember 12, 11, 9, 8, then 7. Everyone has to be the perfect 10. This is intrinsic and this one is extrinsic. For intrinsic, the marker is PTT, for extrinsic PT. Okay, and the TT or thrombin time measures the rate of conversion of fibrinogen. It measures the rate of conversion of fibrinogen into fibrin prolonged by thrombin time, prolonged by anticoagulation. It is prolonged by anticoagulation and hypofibrinogenemia, GIC, and liver disease. Coagulation disorder can be due to either clotting factor deficiency or acquired factor inhibitors. This part is very high yield. Coagulation disorder can be divided due to clotting factor, either clotting factor deficiency or acquired factor inhibitors. It is diagnosed by mixing studies in which normal plasma normal plasma is added to the patient's plasma. If clotting factor deficiency should correct, PT-PTT returns within the normal, whereas if there is inhibitors, it will not gonna correct. This is called 1:1 mixing study. Okay, look at here. If there is elevated PTT, we do 1:1 inhibitor mixing studies. If corrects like PTT corrects, it becomes normal. Think about factor deficiency and give the individual factor assay and evaluate for individual factor assay. Maybe factor 8, factor 9. And if it does not correct, APTT does not come to the normal level, think about the inhibitors. That means test for coagulation factor inhibitors. Test for coagulation factor inhibitor. These are very high health talk. Normal plasma provides coagulation factor. Therefore, it corrects the prolonged PTT in the setting of coagulation factor deficiency. If there is coagulation factor deficiency, if we add normal plasma with the patient's plasma, if it corrects, then it is factor deficiency. If it does not correct, So think about, there is an inhibitor, coagulation factor inhibitor. One of the most coagulation inhibitor is lupus anticoagulant. Very, very, very high coagulant inhibitor is lupus anticoagulant, LA. As a type of antiphospholipid antibody, LA binds to the phospholipids used in most PTT tests and prevents the inducing coagulation, thereby prolonging PTT. This lab artifact is improved with the addition of mixing effect, but is resolved the addition of the phospholipid. The lab artifact is not improved with the addition of the mixing test, but it is resolved with the addition of the phospholipid, which eventually overwhelm all the antibody binding site. So it is not corrected by mixing test, it is corrected by adding phospholipids. Okay, now hemophilia A, B, C, and vitamin K deficiency. In vitamin K deficiency, we know the mechanism 2, 7, 9, 10. So 2, 7, and 9, and all you have to 2, 7, 9, 10. So 7 for PT and 9 for PTT. So PTT is high in fact vitamin K deficiency 2, 7, 9, 10, and protein C and protein S. In here bleeding time is normal, very, very, very high, but in hemophilia factor either 8 or 9 deficiency, 8 or 9 deficiency, PTT is higher because PT is 7, so there is no 7 deficiency. A is for 8, B is for 9, C is for 11, 11 for autoimmune, sorry, autosomal 11 for autosomal recessive, and the A and B is X-linked recessive. Hemorrhage in the hemophilia hematosis, we have found that major bleeding into the joints in the knee, easy bruising, and bleeding after trauma or surgery, dental procedure. Treatment is desmopressin factor 8 concentrate, imicizumab factor A, and the factor 9 concentrate B, factor 9 concentrate B, and factor 11 concentrate C. So A factor 8 concentrate and imicizumab for factor A or hemophilia A, and factor 9 concentrate for hemophilia B, and factor 11 concentrate for hemophilia C. So what factor deficiency give that particular factor? This is a very, very high platelet disorder. All the platelet disorders have increased bleeding time. So all the platelet disorders have increased BT, mucous membrane, bleeding, microhemorrhage, fatigue, but the platelet count is low, PC is low. Maybe normal in qualitative disorder, maybe normal in qualitative disorder. First, uh, Bernard Sullier, then Glanzman, then ITB, then uremic platelet dysfunction. In Bernard Sullier, all have high bleeding time. So all the platelet disorder, Bernard Sullier, Glanzman, ITP, and uremic platelet, all the platelet disorder has increased bleeding time, but platelet count is normal in the Bernard Sullier and ITP. In Bernard Sullier, there is big platelet. Problem Bernard A, B, problem in the adhesion, and Glanzman's problem in the aggregation, G for aggregation, G for aggregation. Bernard Sullier, Bernard is problem in the adhesion problem. Autosomal recessive defect in the adhesion, decreased glycoprotein 1b, decreased platelet to 111 factor adhesion, decreased platelet to 111 factor adhesion, decreased platelet aggregation. There is big platelet and Glanzmann thrombasthenia. Autosomal recessive defect in aggregation, decreased glycoprotein 2b3a. So Barnard is 1b and Glanzman is 2b3a, decreased integrin, decreased platelet to platelet aggregation, and defective platelet plaque formation. Lab blood smear show no platelet clumping. Blood smear shows no platelet clumping. In ITP, destruction of platelet in the spleen. In here, anti-glycoprotein 2b3 antibody. There is splenic macrophage phagocytes platelet. Anti-glycoprotein 2b3 antibody, splenic macrophage phagocytes platelet. Maybe idiopathic or maybe secondary autoimmune disorder, SLE, viral illness, HIV, malignancy, CLL, and drug reaction. And increased lab, increased megakaryocytes on the bone marrow, decreased platelet, increased megakaryocytes on the bone marrow, decreased platelet. Mm, Treatment is glucocorticoid, IVIG, rituximab, glucocorticoid, IVIG, rituximab, thrombopoietin receptor agonist, L-thrombobag, romiflozin, splenectomy for refractory ITP, uremic platelet dysfunction. There is a platelet dysfunction and bleeding time is higher. It is due to renal failure. Uremic toxin accumulate and interfere with platelet. This platelet interferes with platelet addition. So Barnard-Soulier glycoprotein 1b problem in the adhesion. Glanzmann glycoprotein 2b3 problem in the aggregation. Defective platelet to platelet aggregation and plaque formation. ITP destruction of platelet in the spleen. In ITP destruction of the platelet there is antibody formation and uremic platelet dysfunction is like renal failure, uremic toxin accumulates, and platelet problem with platelet adhesion. Okay, now ITP. What two virus should be tested in an asymptomatic patient with the ITP? Asymptomatic patient with ITP, HIV and hepatitis C should be tested. Secondary ITP, there may be initial presentation of HIV infection in 5 to 10% patient. Etiology, immune thrombocytopenia. Etiology is immune thrombocytopenia. Sorry, ITP, there may be platelet autoantibody and maybe preceding viral infection, HIV and hepatitis C. Clinical pedigree, chymosis, mucosal bleeding, isolated thrombocytopenia, less than 1 lakh, few platelet on peripheral smear. Children observe if cutaneous symptoms only, and glucocorticoid IVIG and anti-D if bleeding. For adults, observation if cutaneous symptoms and platelet more than 30,000. If it less than 30,000, again glucocorticoid IVIG or anti-D if bleeding, or platelet less than 30,000, anti-D if RH and Coombs negative, anti-D. Second line therapy is rituximab, thrombopoietin receptor inhibitors, and splenectomy. First line is glucocorticoid IVIG and anti-D. If platelet is less than 30,000, and second line therapy rituximab, thrombopoietin receptor agonist, splenectomy. Platelet transfusion are reserved for life-threatening hemorrhage in patients with ITP. Now TTP. TTP, thrombotic thrombocytopenic purpura. Before jumping into this TTP, I'll look at first here thrombotic microangiopathies. Thrombotic microangiopathy, it may resemble DIC but do not exhibit the lab findings of the consumption coagulopathy like BD is high low fibrinogen but looks like DIC. In thrombotic, typically it is female inhibition or deficiency of ADAMTS13, which is a von Willebrand factor metalloprotease. There is decreased degradation of the von Willebrand factor multimers and increase mm, large von Willebrand factor multimers, and increased platelet adhesion and aggregation, and there is microthrombi formation. Presentation: there is a triad: anemia, thrombocytopenia, anemia, thrombocytopenia, and acute kidney injury. Thrombocytopenia due to decreased platelet, MAHA, anemia, decreased hemoglobin, increased schistocyte, and increased LDH. Mm, These are the common feature for both HAS and TTP. HAS is usually children and usually due to E. coli 0157 H7 hemolytic uremic syndrome and caused by the Zika toxin producing these E. coli 0157 H7. In here, the differentiating symptoms between the TTP and the HAS. In TTP, there is fever and neurological symptom. It is called Raynaud's Splinter. And if it is triad plus bloody diarrhea, think about HAS. Lab in TTP, normal PT, PTT helps to distinguish TTP and HAS. In here, normal PT and PTT. Coagulation pathway is not activated from DIC. Coagulation factor is not activated. And in TTP, plasma exchange, glucocorticoid, and rituximab, plasma exchange, glucocorticoid, and rituximab. And in HAS, you should not give antibiotic and supportive care. Now, usually in our circle, TTP decrease Adam TS13, which is a von Willebrand factor metalloprotease, uncleaved von Willebrand factor multimer, and platelet trapping and activation. There is acquired autoantibody or hereditary anemia, thrombocytopenia, acute kidney injury. There is fever and neurological symptoms. Plasma exchange, glucocorticoid, and rituximab. In three things you can give: plasma exchange, glucocorticoid, and rituximab, anti-CD2 and anti-CD20 anti. TTP is life-threatening and must be treated urgently with plasma exchange. This is very high. Packs. Packs should be given immediately if you diagnose. Packs removes the patient's plasma and replace the donor plasma and replace it with the donor plasma. These replenishes the Adam TS13 and removes autoantibody. So packs. Without emergent packs, the mortality rate is approximately 90%. If you diagnose PTT, go for plasma action. Now has hemolytic uremic syndrome, E. coli 157H7 serotype, or Zika dysentery. There may be vascular damage and microthrombi. Again, anemia. Lab is anemia, thrombocytopenia, acute kidney injury. And with this study, if there is bloody diarrhea with fatigue, pallor, bruising, fatigue, oligoedema, in here, fluid and electrolyte management, blood transfusion, dialysis. Treatment for prodromal diarrhea with antibiotic. Treatment of prodromal diarrhea with antibiotic and anti-motility agent, as in this case, can increase the risk of developing HAS and is not recommended. So treatment for prodromal diarrhea with antibiotic and or anti-motility drugs. So antibiotic, anti-motility drugs is not recommended in hemolytic uremic syndrome. Finally, the mixed platelet and coagulation disorder, von Willebrand disease, and the DIC. In von Willebrand disease, PTT is high, bleeding time is high, and DIC, platelet count is low, bleeding time is high, as it is mixed platelet and coagulation disorder. We have already seen that in platelet disorder, increased bleeding time, and in coagulation disorder problem, the PT and the PTTs. So platelet goes with the bleeding time as well as a platelet count. But coagulation disorder is PT-PTT, as it is mixed platelet and coagulation disorder. So this is one Willebrand factor. Intrinsic pathway coagulation defect decrease quantify and or function of the von Willebrand increased PTT. Von Willebrand factor carries the protective factor factor 8. Von Willebrand factor carries the protective factor 8. And defect in platelet plaque formation decrease von Willebrand factor. Defect in platelet to von Willebrand factor adhesion. Defect in platelet to von Willebrand factor adhesion. Most are autosomal dominant, but common inherited bleeding disorder commonly presents with menorrhagia or epistaxis. Treatment is von Willebrand factor concentrate desmopressin, which releases von Willebrand factor stored in the endothelium. Desmopressin is given in where nocturnal aneurysms, where in central diabetes insipidus. These are the common area where desmopressin, and another is 111 factor, very atypical. DIC. The causes of the DIC, it can cause heat stroke, snake bites. So heat stroke, snake bite, sepsis, trauma, obstetric complication, pancreatitis malignancy, and nephrotic syndrome, and transfusion. So DIC, widespread clotting factor activation, and thromboembolic state with excessive clotting factor consumption. Thromboembolic state with excessive clotting factor consumption, increased thrombosis, increased hemorrhage, and blood oozing from the puncture site. Maybe acute, life-threatening, or chronic if clotting factor production can compensate for consumption. In lab, there is cystoside, increased fibrin degradation product, D-dimer, decreased fibrinogen, decreased factor 5 and 8. Okay, now the DIC. In acute DIC, there is stop stop making thrombi like sepsis, trauma, and obstetric complication, and chronic for malignancy. An acute coagulation study, PTT, is higher in chronic, often normal. Platelet count is low, fibrinogen is low in acute, but chronic it is normal. D-dimer in high in both cases, in acute and chronic both cases, and bleeding risk is higher in very high is acute DIC, but chronic DIC mildly increased, thromboembolic risk mildly increased, and very high. So bleeding risk is very high in acute bleeding in chronic. Chronic thromboembolic risk. Now, hemophilia. What is the likely diagnosis in adolescent with a history of hemophilia A that presents with worsening pain and limited motion of the knee? It is hemophilic arthropathy due to hemosider iron deposition leading to synovitis and fibrosis within the joint, and risk is significantly reduced with prophylactic factor concentrated. Narrow joint space, subchondral space. There is articular surface erosion. Inhibitor development occurs 25% of the severe hemophilia A. As a complication of the treatment, the immune system recognizes the infused factor as foreign and forming antibody that interferes with factor dysfunction, and therefore an inhibitor should be suspected. Then inhibitor should be suspected when a patient with hemophilia, A or factor replacement therapy develops an increased bleeding. When hemophilia or factor replacement therapy develops increased bleeding frequency, think about refractory to the treatment. Think about there is inhibitor development. Treatment of the acute bleeding patient with inhibitor development. Treatment of the acute bleeding inhibitor development often involves bypassing the product. Recommended factor 7 or activated PCC. So you need to bypass such as agents work downstream in the coagulation cascade to promote clotting factor without the need for factor VIII. So such as agents that work downstream in the coagulation cascade to promote clotting without the need for factor VIII. So you should use things that not goes through the factor VIII. It goes to the other pathway of the coagulation cascade. Okay, finally, hereditary thrombophilia. In hereditary thrombophilia, factor 5 Leiden, there is activated protein C resistance, most commonly white ethnicity. Prothrombin mutation, increased prothrombin level. Second, antithrombin C, it is inherited, acquired DIC cirrhosis, and nephrotic protein C and S, decrease activation of the factor 5 and factor 8. Factor 5 and protein C and S deficiency cause warfarin induced skin necrosis. Only protein C only. Okay, now from the first state, the hereditary uh, thrombophilia. So hereditary thrombophilia. Wait. Okay, hereditary thrombophilia. autosomal dominant disorder resulting in hypercoagulable state. Antithrombin deficiency has no direct effect on the PTT thrombin time but diminishes the increase in the PTT following standard increased PTT following standard heparin dose. In antithrombin can also be acquired renal failure nephrotic syndrome. Antithrombin loss in the urine, antithrombin loss, decrease inhibition of the factor 2A and 10A. Factor 5 Leiden, there is production of the mutant factor 5, production of the mutant factor 5, guanine, adenine, DNA point mutation, arginine, 506, glycine a mutation near the cleavage site that is raised in degradation by the protein C. Complication DVT, cerebral venous thrombosis, and recurrent pregnancy loss. Factor 5 Leiden patient has recurrent pregnant loss. So protein C or proteinase, protein C cancel and proteinase stops coagulation. C cancels and increase risk of warfarin, skin necrosis, and prothrombin G2021OA mutation, point mutation of 3' untranslated region, increase production of the prothrombin, increase plasma level, and venous clots. Okay, this is all about the bleeding disorders. Hope you enjoyed. Before finishing,